So when we're interpreting the narrow complex tachycardia, one of the first things that we want to think about is the rhythm regular or irregular? First off, if we've identified that it is a narrow complex tachycardia and it's a regular rhythm, we're going to think about some of the more common rhythms that can cause this. So number one is sinus tachycardia. So it's going to be above 100 beats per minute, and it's caused by increased automaticity, where there's increased sympathetic activation. The P wave is going to be coming from the sinus node, and therefore we're going to see a typical pattern of the P wave. It's going to be upright in lead 2 and down in AVR. In V1, you'll commonly see either an upright P wave or a biphasic wave, as you can see here. So number 2 is atrial flutter with 2-to-1 conduction. So this is an arrhythmia that's often missed. So it's caused by a re-entry mechanism within the atria, and what we're going to see on the ECG are flutter waves or F waves that create a sawtooth pattern. The most reliable leads for F waves are V1 and sometimes V2. Sometimes they can actually be superimposed on the T waves, so it can be quite difficult to tell what's an F wave, what's a T wave. And normally these flutter waves, the F waves, are negative in the inferior leads 2, 3 and AVF in the typical counterclockwise atrial flutter. Another classic finding is that the atrial rate is approximately 300 beats per minute, so one big square, and the ventricular rate is approximately half that, so around 150 beats per minute. So if you see a narrow complex tachycardia at 150 beats per minute, make sure you look for flutter waves. And finally, for the regular narrow complex tachycardias, we have SVT, or supraventricular tachycardias, which actually covers a group of tachycardias. Sometimes it includes flutter and atrial fibrillation as well. But here are some of the types of SVT. So you have focal atrial tachycardia, AVNRT, AVRT, and a junctional tachycardia as well. So the most common of the above is AVNRT, but in this video we're just going to start by looking at focal atrial tachycardia, and we'll come back to the rest in a few videos' time. So in a focal atrial tachycardia, we have a group of cells firing and depolarizing the atria that aren't actually part of the sinoatrial node. This could be due to a few different mechanisms, increased automaticity, and also triggered activity as well. The P wave is the key finding in FAT, focal atrial tachycardia. The location of the P wave will give you an approximate location of the ectopic focus. For example, if it's coming from the left atrium, one of the lateral leads, AVL, would give you a negative P wave because it's traveling away from the left atrium towards the right atrium. And AVL is typically going in a leftwards direction. So in this case, we can actually see a negative P wave in lead 2, which is abnormal, positive in AVR, again, abnormal, and there are also negative P waves in the inferior leads. So this makes you think that the actual focus that's depolarizing the atria is closer to the AV junction because it's depolarizing the atria in the opposite direction, inferior to superior. Another finding supportive of focal atrial tachycardia would be if you saw the warm up and cool down phenomenon, because typically it's an automatic tachycardia. Generally, focal atrial tachycardia is benign, and it's often precipitated by an underlying illness, but it can also be due to toxicities like digitalis, like theophylline. The rate is typically going to be 100 to 200 beats per minute.